Hello, my name is Gemmy Cheung. I'm from the Singapore National Eye Centre. It is my great pleasure to participate in IOCS 2021, and I'd like to thank Professor Ugura and Dr. Amani Falsi for the kind invitation. My topic will be about differential reperfusion patterns in the retinal vasculature following increase in intraocular pressure. Intravitreal injections are one of the most commonly performed procedures in ophthalmology nowadays. We recognize there can be transient rises in intraocular pressure after each injection. However, we know that the risk of incident glaucoma has been reported as low. In addition to the potential effect on the optic nerve as well as ganglion cells, there could also be effects from these kind of transient rises in intraocular pressure on the retinal vascular perfusion. Therefore, the purpose of this study is to describe the patterns of reperfusion in the retina and choriocapillaris as detected on OCT angiography following an increase in intraocular pressure by intravitreal injection in a non-human primate model. We injected a volume of 100 microliters of saline intravitreally and performed OCT angiography before injection and serially post-injection up to 14 minutes. Concurrently, we recorded the systemic blood pressure as well as intraocular pressure at several time points. This is the experimental setup, and subsequent interpretation of the OCT angiography images will be based on our understanding of mean ocular perfusion pressure. Mean ocular perfusion pressure, in turn, is determined by mean arterial pressure at the optic nerve head against intraocular pressure. Mean arterial pressure, in turn, is dependent on systolic and diastolic pressure, and the equations are shown here. So just to demonstrate, before injection on the right-hand side, we have this SVP OCT angiography. At this time point, intraocular pressure was 9. The mean arterial pressure was 63 millimeters mercury, and the resultant mean ocular perfusion pressure was 33 millimeters mercury. Immediately after the intravitreal injection, intraocular pressure was recorded at 98 millimeters mercury. We observed a transient occlusion of central retinal artery followed by pulsation. Within 30 seconds after intravitreal injection, we can start to observe return of flow in the main arterioles and venues. This is in the superficial vascular plexus. However, defects within the perfusion of the capillary bed can continue to be observed even with the naked eye up to between 3 to 4 minutes. By 7 minutes, intraocular pressure had returned to 22 millimeter mercuries, and by 40 minutes, 11 millimeter mercuries. The corresponding OCT angiography and mean ocular perfusion pressure are shown here. Based on these observations, there are a few study questions we'd like to ask. First of all, does perfusion fully recover by 40 minutes? Here are the pre-injection and 40 minutes post-injection OCT angiography of the SVP. Here are the DCP. In the DCP, even with naked eyes, it is observed that some of the capillary beds still have not fully recovered the perfusion. And this is the choriocapillaris. When we study quantitative readouts of the vessel density, we observed that at 40 minutes, there was still 15.8% of reduction compared to baseline in the SVP, whereas this is even more marked in the DCP, which is reduced by 31%. And this is the vessel density map, pre-injection on the left and post-injection on the right. The next question is whether there is a difference in the pattern of reperfusion in the 3 vascular plexuses. I have already shown you the recovery pattern in the superficial vascular plexus. Note that return of flow in the main arteriole and venues was observed as early as 30 seconds, and capillary bed recovery was quite well observed at about 3 to 4 minutes already. In contrast, these are the serial OCT angiography of the same eye of the deep capillary plexus. Note that return of flow was delayed to about 1 to 2 minutes, which is later than what we observed in the SVP. In addition, there were obvious residual perfusion deficit, which is well observed at 4 minutes and 7 minutes. In the choriocapillaris, there was return of flow early by 30 seconds, but some deficits are noted up to 3 minutes with the naked eye. So comparing these three slabs together, we would conclude that recovery of flow was lowest in the deep capillary plexus. And the third question many of you must be itching to ask is, are those dark bands artifacts, or what are they? We believe these bands are not artifacts, but there is indeed a physiological explanation for them. This is because we can observe these bands across every slab that we are studying, and they are consistently observed in different animals scanned as well. Furthermore, the spacing of them are regular, which does suggest there is a physiological process underlying. Let's consider what is happening in the scanner. We know that we are using a fast scanner, which is scanning at 100,000 A scans per second. Therefore, to scan the 3 by 3 mm scan area, the acquisition time will be about 3 seconds. During these 3 seconds of acquisition time, the animal would have experienced about 6 cardiac cycles, as this fits with the heart rate recorded in the anesthetic record, which is about 120 beats per minute. Therefore, our hypothesis is that this observation of alternating flow bands versus dark bands of no flow actually represents systole and diastole in each of these animals. Note that these bands persisted up to 2 minutes and were not present anymore during the 7 minutes or the 40 minutes scans. And this is because during the first 2 minutes, intraocular pressure was still very high and slowly coming down from the rise to 98 millimeters mercury. Probably during this time, only the systolic pressure was able to overcome the intraocular pressure, whereas the diastolic pressure in the macular area scanned was below the intraocular pressure, resulting in the observation of no flow signals. These bands observed up to about 2 minutes, and by 7 and 14 minutes, when we know that the intraocular pressure had stabilized some more, the bands were no longer observed. So in conclusion, our findings demonstrate that intraocular pressure rise post-intravisual injection can affect the retinal vascular perfusion. Despite normalization of intraocular pressure at 40 minutes post-injection, we observed focal defects in all layers. Amongst the 3 layers studied, the deep capillary plexus appears to be the most susceptible, as demonstrated by both having the slowest recovery as well as the most persistent defects at 14 minutes. We recognize there are several other questions to follow up on. For example, is there going to be recovery beyond 40 minutes? Are there going to be cumulative damage with repeated intravitreal injections? And finally, if we inject anti-VEGF, will the pharmacological effects salvage the situation? We hope to answer these questions in the next set of experiments and hope to come back to report to you the results. Thank you once again for the opportunity to share our findings.